morning to all of us here. My name is Dr. Madan. I pioneer plastic surgery institute in Medical College. Yes, about SYNDACTYLY. This 20-year-old male patient, first-born male patient born of non-consanguineous marriage, to present with complete fingers of the left hand since birth. There is no history suggestive of associated congenital anomalies. Patient was born of full-term normal vaginal delivery. Past history, patient from birth, patient had fusion of all fingers of the left hand. He underwent surgery for release of index finger from the middle finger in 2009, and he underwent surgery for release of little finger from the ring finger and thumb web release in 2019. Now he has presented with fusion of long fingers and the ring finger, for which he wants to undergo surgery. There is no history suggestive of any developmental delay. Patient of normal school along with the other siblings. Family history is not nil significant. No any history suggestive of family history suggestive of fusion of fingers in other family members. Patient is immunized as per schedule. Undoubtedly, there is no history of any infection or drug exposure in the mother in the past, as per the patient and also as per the father of the patient. Gender examination, patient is active and vitals are stable. There is no evidence of clear express cyanosis, clubbing, lymphadenopathy or edema. There is no visible congenital defects as per gender examination, such as chest wall deformity, left parietal with any facial deformity as per my examination. Patient was examined in the sitting posture, the left shoulder in abducted position, well into with the elbow flexed. There is fusion of middle finger to the ring finger, extending from rib space till the point proximal to the distal interphalangeal joint. Just proximal. Thumb rib space is narrow with the absent interphalangeal joint crease in the thumb, in the palmar surface of thumb. And there is a distal crease noted over the little finger and the index finger, and proximal distal crease noted over the little finger root, but the index finger does not show any proximal distal crease. There's a distal crease between the middle and ring finger, which is present at a higher level compared to the index and little finger. There is no obvious deviation of the finger. There is no obvious limit and discrepancy between the fingers. Middle finger is found present with flexion deformity. It's noted in the dorsal surface. The palmars and nails are not fused to one another. You said there is no discrepancy.
The fingers are the same size.
Compared to the right side, there is a hypoplasia of the.
So why did you say there is no? Slightly confused.
No apparent deviation is not seen.
No deviation, I thought you said
So
size.
you can see, no? So see the obvious.
Hypoplasia of the.
There is, right? There is a difference in size.
Size.
So say it
Right
again.
and there is a
Say it
difference in size between the right and the left hand, with the hypoplasia of the thumb also noted on the left hand compared to the right hand. There is hyperpigmented scar present on the ulnar side of the index finger and on the radial side of the little finger. Similarly, hyperpigmented scar of post-surgical scar noted on the radial side of the middle finger and the ulnar side of the ring finger was noted. The range of movements at the MCP joint level and at the DAP joint level are normal. Patient is able to flex and extend. Distance sensations are normal as per examination. And the patient.
So you said MCP,
DAP.
no PAP.
No PAP.
So you can mention that.
Still, there is no. It is only differential.
You said there is no deviation of the finger. What about the little finger? Can you see?
The little finger. Just look at
Is it there?
just look at this picture. You might have to come in front.
Maybe it is seen in photograph, not physically, but it is there in photograph.
But it has the scars from previous life. This kind of deviation, if seen from as a just that, let us say the patient comes with just that kind of deviation, right? But what is that? If you see the deviation, then you'll be able to tell what it is. That little finger shows a little bit of deviation.
What is it called?
If it is not associated like this, let's say that let us say the child is, mother brings the child with this deviation of the little finger. What diagnosis, what spot diagnosis will you give? Time. So you can see it.
And then dermatoglyphics also is.
So the patient is having a distal palmar, but no proximal palmar. These are mainly present. Sir.
What about the first wave space? You didn't tell about it.
NABI first wave space for inspection and release of first wave space in 2018.
Sorry.
The less space that you mentioned, I can tell you.
Yeah, go ahead.
My diagnosis, the patient had X-ray with him when I was examined. That is only diphalangeal fingers with the presence of delta present over the little finger and over the middle finger, short phalanx present over the little finger and the ring finger of the patient. And only in little ring, middle and index finger all had diphalangeal presentation. This is a case of there is only no complete syndactyly, it is only incomplete, no fusion of landings and complicated because of there is a absence of digit syndactyly between middle and ring finger, type of hypoplasia of left hand.
Saying complicated sentence. Why it is complicated? Because it is biphasic.
Patient also has global hypoplasia of the left hand.
How do you classify syndactyly?
Simple, it is incomplete or complete. Incomplete is simple is when there is no bony fusion. When there is a soft tissue union, when it involves the up to the fingertip, it is called complete. When it does not involve
Complete is different. Simple,
complicated, complex. Simple is only soft tissue union. Complicated is distal bone fusion, and complex is when it is associated with any absent or missing fusion of joints or syndactyly, very skeletal abnormality.
Since these are shorter fingers with absence of phalanx, what diagnosis would you give? Would you call it complicated syndactyly or some dash syndactyly?
Brachysyndactyly, case of brachysyndactyly, short finger type.
Brachysyndactyly.
Complicated because it doesn't fit in your topic.
But it is a brachysyndactyly. That is what is more important.
What is the specific issue with complex syndactyly or complicated complex syndactyly when you have got bony fusion? What is the issue clinically or during surgery?
Sir,
We are worried about that.
when there is fusion of joints, it is a very
Not joints, it's adjacent distal phalanges.
the vascular compromise can happen in intraoperative. You should expect vascular because the patient will only supply from one side, either from the radial or ulnar side.
So it is a surprise. What they could be a digital message, there could be a single, there could be a single digital, or occasionally the separation of the two is more distal.
More
So
distal
you will have to
component.
give up more often than not. That's what happens in a brachysyndactyly. You open it, you will say that there are distally you may find proper on both sides, but then it's separating. Very distal.
Another problem with complexes, you have got bony fusion. So when you divide, you have got bare bone on two sides. So how do you cover that?
Sir, we have to cover with the triangle collapse later.
What technique?
What's technique of lots of web background technique of India.
What is the word?
It is a elevation of a triangular bulb flap from the adjacent tip to reconstruct the tip of the
It is triangle pulp flap.
Investigation, patient already has taken X-ray. Echo for example, not any other kinds of problems. For release the syndactyly between middle and ring finger. Marking, I mark first the axis of the middle and ring finger and the axis from the proximal finger. I mark the axis of middle ring finger as A and B and dorsal metacarpal flap is elevated up to the level of 2/3 of the length of up to 2/3 of the distance between the MCP and PAP joint and width of distance between two metacarpals and incision is extended approximately up to the PAP joint and to the middle of the PAP joint. And since it is incomplete, I will cross over and make a similar flap covering the proximal interface joint for the patient and dorsal metacarp flap to cover the create the first third web spacing.
How much you will be able to cover with the normal skin?
Sir,
What you will do with the remaining?
sir, I will use a full thickness skin graft. There will be raw area or the I keep the flap in such a way it covers the ring finger and the palm of flap covers the ring finger. There will be a defect of in the ulnar aspect of the middle finger and there will be a defect present over the distal aspect of the ring finger, sir. For which the patient has already undergone surgery in 2008 for which is graft from left groin was removed and use right groin side for full thickness skin graft coverage of the defects. And for
Principally, when you are creating these incision lines, what is the one thing where you want full thickness skin to cover? There are many methods to use syndactyly, but there are certain principles of syndactyly which you want to complete release, yes. And then you've done a complete release. Now you want to resurface, and you're using the same, adjusting the same thing.
we will excise the soft fat judicially such that the flap covers the.
Which part, where it should cover?
The flap should cover the joint regions, joint region and the
Yes,
space.
more
What is the most important part of the raw area which you will
Left place
cover?
space.
Huh?
Left place.
Let's see. So what are the options? What madam is asking me, what are the options, flap options to cover the web space? Techniques is
there are
you have made already one quadrant.
dorsal metacarpal flap.
Dorsal flap.
Another is clover leaf shape for manta type flap. Another is
So our choice is usually a dorsal flap or volar flap.
dorsal. Sir, normal web is
Anything about an angle
dorsal
of that
to
dorsal flap.
45 degree angle.
And sometimes you can also insert a volar flap going into that. You can divide that. It opens up, it goes on both sides and a volar flap.
Any island flap?
DY island volar flap can use PR max.
The idea is to cover with the dorsal skin the web space thoroughly. No raw area should be there. Rest of the area you can decide about
Yeah.
your local flap, your full thickness graft, split thickness graft, whatever you want.
Other thing is that in a patient who has who is a case where all the fingers were joined together, you will always have prior incisions. So when you are taking your incisions for your earlier syndactyly release also, keep in mind that you have to finally do all the others. So which scar are you cutting into and all those things also. Just mention it, that is you don't want a straight line, therefore the zigzag.
This patient has single IP. Isn't it? You have made two triangles on both sides to cover two joints. Why? You see? You have made in such a way, even the palmar crease you have made other fingers, they are for triphalangeal joint. So when you present a case, you must be careful that you replicate your planning based on the case which you are presenting, not on what picture is there in your book. Okay?
Other thing is that even if there are no IP joints, but you are free to make more Zs. You're free to do that because you don't want them to be very large and have straight lines. So it's okay to do, but you can't have those lines which don't exist. You can have more Zs. It's okay.
Any amount of Z.
You can have any amount of Zs so long as they interdigitate with each other and they give you good condition. Making sure that your one large Z or flap is sitting over the joint wherever it is here. It's not in its normal position, right?
You, in your examination, general examination system, you said you will examine the chest. Why?
Sir, sometimes syndactyly will be associated with colon syndrome as a part of the syndrome. In this patient, ipsilateral hypoplasia of sternal net of pectoralis muscle with global hypoplasia of the hands. This patient did not have any chest circumference and nipple region or normal in both legs.
You said what is colon syndrome? Absence of
sternal net of pectoralis hypoplasia of sternal net of pectoralis major and this breast is
what breast? What happens to the breast?
There will be mass.
Madam is answering on your behalf. She will not be there. So you must know about the colon syndrome. Second, when you have got syndactyly, you must know about the craniofacial anomalies, Cruzen syndrome, Eckert syndrome. What are the special types of syndactyly and Eckert? What is the difference? What are the different types of mitten hand? What is the approach to all these? You must know about that. You don't need to answer now.
Also discussed. In the history you mentioned that the first release was of the index finger with the middle finger in 2009 and the next one was only 2019 of the little finger with the ring finger. Do you think this sequencing was good, right? Or do you think that if you were the surgeon you would have done something better?
We should have released both index and middle finger and ring finger and little finger in the same sitting. Distal
Also because the little finger and the ring finger there is a size difference. So that little bit of angulation that has happened because it's trying to.
Why you stagger? See, you said you will do the, that plan was not correct. You will do the fourth space and secondary space in one sitting. Then middle one you will do at the next sitting after 6 months or something. Why? Why not to do all of them together? You are reconstructing whole head, neck, face.
Tongue is also there. Tongue was also done. So then your sequence changes.
Sir,
Why not to do everything together?
sir, there may be vascular compromise done for fingers at the same time. Sir. We have to check the vascularity before release the tourniquet, check the vascularity of the fingers intraoperatively in both the marginal fingers before completing the surgery.
But you will not do it. Everything is okay. Then at that time, will you go ahead with the middle finger, with the third? You will not do it. But Dr. Joseph's point is right. What about the first web? That was done in 2019 only, you said. In a normal course of events, if it's a very tight one like this, what do you do first?
First, thumb web, creation of thumb web should be done.